which was a Medi-Cal HIE incentive program that the Department of Healthcare Services ran, just to hear a little bit more about some of the outcomes from Cal Hop. And then we'll just touch on some news and events and policy updates after that. Please feel free to introduce yourself in the chat if you'd like to today, and please feel free to enter questions or comments or thoughts in the chat as well, and drop in links too. Just to review a little bit more about the coalition, our vision is really that, connected health data is the standard across the state. We really work to support policy that builds capacity to support provider and plan participation and individual participation as well. And really policy priorities for the year have really been focused on funding, defining what the data sharing mandate looks like and what data needs to be shared and who needs to share it, building the needed statewide infrastructure and leveraging our existing infrastructure and HIEs and such. And then also making sure that, we see through the promise of AB 133 through the state's data exchange framework. So just quickly moving to our next slide. Just to remind folks of these 7 ingredients that we've come up with around the data exchange framework, and the key things that we're keeping our eyes out for when it comes to data standards and consent, infrastructure funding, identity management, governance, and patient consumer engagement. And really to focusing on our key use cases around immunization and COVID data, and CalAIM as well. And I think, as we'll hear today, a little bit coming through, and I think the Wic presentation around, those linkages when it comes to CalAIM and public health, as well as we think about threading together, our healthcare ecosystem and making sure we can get data shared. So with that, I think we can go ahead and hand it over to our friends Karen and Linnea with the California Wic Association. So I'll hand it over to you both. Karen, you're muted.
Yep. Thanks for inviting us to this meeting, and I just want to express gratitude for this coalition. It's really informative and helps us all become educated, and we're encouraging the WIC agencies to also attend and learn. It's definitely a learning process. So we're just going to briefly share some information with you today about how we're trying to learn about linkages and promote linkages for the WIC agencies across California. So I'm Karen Farley, the Executive Director of the California Wic Association, which is the state association for the 84 local agencies that provide WIC benefits in California. And with me is Linnea Salick, who's the former California WIC director and has a long history of state and national work. I'll let her introduce herself in a couple slides in, but we're very grateful and privileged to work with Linnea on this project. So next slide, please. I just wanted to give you a little bit of information about, called the nutshell explanation of WIC, but WIC is 100% USDA funded. It doesn't receive state funding. There is some money in the budget this year for some books for WIC, but that is not WIC funding. For the USDA WIC program, it's funding for the WIC agencies, a little different in case you happen to see that when you're reviewing the state budget. The California Department of Public Health manages the WIC program, contracting to the 84 WIC agencies, and we're going to talk about some differences about those and related to linkages. And services have historically been all provided in person, and now there's a shift to also allowing the choices for remote for some visits. The WIC groceries items have to be procured in grocery stores, and those are authorized with the Department of Public Health. And then there's about 4,000 grocery stores and a growing number of farmers who can provide the WIC foods. For the farmers, it's the fruit and vegetables, but in the grocery stores, it's quite a diverse, large, healthy bag of groceries. The 84 agencies have about 600 brick and mortar sites across the state. And just to quickly summarize the staff, there's about 3,000. They're highly trained in nutrition and lactation, but also in motivational interviewing. And they have expansive language and cultural capacity, coming from the community where they live, living in the community where they work. And now the last couple of years, they're quite proficient in a number of technologies for managing the information and the data, but also in providing the benefits. So next slide, please. So a number of years, we started working with partners, doing some advocacy around helping WIC become more linked across the continuum of care. And we knew that WIC is not well linked. WIC is federally qualified to give out a lot of referrals and connect with other programs. And historically, WIC was always hoping they would get more referrals to the program. And then a lot of technology innovations came along, and the whole kind of shifting of how we link programs and give referrals and share data and do care coordination. So we did a survey of the WIC agencies and in 2018, and then just last year released this report under a COVID and JEDI framework. And so this report summarizes the findings of that survey of the WIC agencies across the continuum of care. And that's available for sort of the grounding of the work we're doing. So next slide, please. What's important to understand when you think about linking the WIC programs, the local WIC agencies, is where they are administered locally. So different from some other public health programs, WIC agencies are in these 6 types of local organizations. And you can see of the 84 agencies, the numbers of WIC agencies that are in, say, county health departments or Native American health centers or the other 6. And then the percent of what we call caseload, that represents the number. The caseload is what USDA provides, representing the number of individuals that agency is being contracted to provide services to. So you can see the FQHCs, county health departments, and the nonprofit organizations, those having no administrative connection to healthcare, serve a majority of what we call the WIC participants. So you can see that WIC is not in schools. I see that question there. It's in these local administrations. So next slide, please. And just briefly, we know you're aware of all these initiatives, but we're going to talk today about some local connections, but we're very aware and hopeful that these opportunities listed here have opportunities for WIC. WIC is not included in the CalSAWS, current set CalSAWS work. We're closely tracking opportunities in CalAIM. We're doing a lot of groundwork, hoping that the Medi-Cal contracts will have some opportunities for WIC. And then, we're tracking the governor's proposed solutions for referrals and in the bigger statewide picture. So next slide, please. And then just drilling down a little bit further, we're really appreciative of the work of that the organizations did for the SHIG and local regional and local linkages, and that's what we're going to talk about today. And as we get into those linkages, we're learning about all these new partners, like some of you on the line. So next slide, please. Just a quick overview. What WIC is looking for are opportunities, and it falls into sort of 3 buckets. Referrals to increase referrals so that we can turn those into enrollments for WIC. Streamlining the operations to improve WIC retention. Participants can participate in WIC from their pregnancy through up to 2 years postpartum and up to 5 years for kids, but there's a drop off there. And then WIC staff need to communicate with healthcare providers for care, and they need some clinical data, and they need to communicate on certain issues to provide the needed care for the participants. So those are sort of the 3 major buckets that we're looking to for opportunities. Next slide, please. I think this is, I don't have my notes, so I think this is you, Linnea.
Sure, thanks, Karen. As Karen mentioned, my name is Linnea Salick. I'm working as a consultant to the California Wic Association, and I consider myself to be a WIC lifer. My career spanning several decades has been with the WIC program, including, as Karen mentioned, with the California WIC program. When I left California WIC, I went to work for a national nonprofit that does research and consulting services to WIC programs all across the country. So I have expanded my knowledge beyond California into understanding how other states operate their WIC programs as well. And a lot of the work that I've done over the last decade has been around this kind of focus on streamlining, on making the program more accessible, easier for families to access and use. And certainly data linkages and data exchange is a key part of that. So really happy to work with CWA on this initiative. So in the information that we've gathered through the survey Karen mentioned and through discussions with the local programs in California, we've learned that WIC is currently exchanging and accessing data through linkages with healthcare, with CalFresh, with Medi-Cal, with other community programs and organizations. And the linkages are occurring either by WIC receiving data from others, largely in the form of referrals, by WIC referring participants to other programs and services. And in some cases, and we really hope to expand these cases, by WIC having access to data that they can use to do targeted outreach and enroll and keep families participating in the program. While there are WIC agencies that do have these more electronic forms of data exchange in place, there are many that aren't currently set up to do that, especially WIC agencies that are embedded in nonprofit organizations where they're not, their mission is not providing healthcare services. So we're working to share the existing models that we've learned about and to support other WIC agencies in adopting those models or in trying new data exchange models. Next slide, please. There are promising linkages between WIC and healthcare, and one of those is in the form of WIC programs having access to electronic health record systems. Now, these are largely and almost exclusively WIC programs that are embedded in agencies that are providing healthcare, federally qualified health centers, county health systems that provide healthcare. But this is probably the predominant form of electronic data exchange that we are aware of. There is a lot of variation in that, though, in that some WIC staff have access to the EHRs where the WIC staff actually have accounts, they log on. All WIC staff are able to access the EHR, get the data for doing enrollment or recertifying participants in the program. Others have a much more limited view. There depends on sort of the policy around the use of the EHR in the organizations where they exist. So in some cases, only a limited number of staff are able to access the EHR, have a limited view. There's also variation in what the WIC staff can do in the EHR. Some of them can only view a limited subset of information, while others have a wider view and are more engaged in communication back to providers and in the more global patient care process. The latter example tends to be more registered dietitians and lactation consultants who are part of the patient care team. There are a couple of ways that referrals are being made to WIC through the EHRs. In some agencies, the EHR has been set up to send a referral to WIC through like an inbox messaging functionality. In others, there's more of a referral field that's embedded in the actual patient care script. So we've learned about a couple of different ways that the EHRs are being used for referrals. In the WIC agencies where the WIC staff have access to EHRs, we didn't hear of any that needed specific MOUs for this because the WIC staff are employees of the organization. So they are able to access those through their employee relationship with the organization. Next slide, please. Just a couple other things we learned. Access to EHRs is available, as I mentioned, mostly to WIC agencies that are part of organizations that have healthcare as their mission. We did not learn about others, especially the nonprofits that are able to do this. There are a lot of, this is not news to folks on this call, lots of different EHRs in use, lots of different ways so that referrals can be made. So we didn't dig into the specifics of these different EHRs when we were learning about this from the agencies, but that's something we're currently engaged, is really trying to understand how these different EHRs operate and what the opportunities are for particularly referral and communication about patient care. All of the agencies that have access to patient records in the EHRs, raved about how much it helps in streamlining the certification process, because it gives them access to measurements and blood test results and information about participation in Medi-Cal, other data that is needed to certify a family, individual into the WIC program. Some also said that because they have access to the HR and communication providers, really makes it much easier for them to address special needs like infants that might need a therapeutic formula or women who need lactation support. So that has really been a plus in those agencies. There's a lot more to unpack on this. And as I said, we're currently working to learn more about EHRs, especially how they could be used to make referrals and to facilitate communication between WIC and healthcare. And next slide. The other one that I wanted to touch on as far as linkages with healthcare are the linkages with health information exchanges. WIC agencies that are part of county health departments may have access to these. We are aware of a couple of different models of this, where in some cases WIC staff, all WIC staff can have log-on accounts to view data in the health information exchange. The data in one of the models we learned about actually goes beyond the patients of the health department that into relationships with other providers in the community. So in some cases, WIC agencies are able to access the necessary information for WIC enrollment for a large percentage of the families that are applying for services. While not all counties have health information exchanges in place, for those that do, it really could be a gold mine in terms of making it easier to both enroll families that are referred to WIC, but also potentially providing some opportunities for some data matching between WIC and the health information exchange to do targeted outreach to people that aren't enrolled in the WIC program. Next slide. I wanted to mention that California Wic Association is currently working with another nonprofit, Nourish California, to facilitate pilots between WIC and health information exchanges. And there's 2 pilots currently underway with WIC agencies that are collaborating with the HIEs in their counties. One of these is really specifically focused right now on setting up a referral mechanism for providers to send electronic referrals to WIC, and for the WIC to then access the information needed for enrollment through the HIE. And we're really excited about this pilot because the WIC agency in this particular case is a community-based nonprofit that's not affiliated with healthcare. And so if this is successful, it could be an important model for the WIC agencies across the state that are serving a large percentage of the population, and they're in nonprofit organizations. And then the second pilot is a WIC agency and health center in Los Angeles that has been given access to records for their center's patients in lanes. And they're currently exploring how best to use this, both for accessing information to enroll and certify families, and then also what the opportunities are to do outreach to patients served by their health center who aren't currently enrolled in WIC. And so their next step is to work with an IT contractor to really customize the view of information in lanes for WIC use. So we're really enthusiastic about these pilots as being opportunities to really better understand how WIC can engage with health information exchange. Next slide. And Karen, I think you were going to touch on this. You've had a lot of communications with community information exchanges.
Right, and I see Reed's on the line from Unite Us. Yeah, so across the continuum of care, there's electronic health records, the HIEs, there's other points on the continuum of care in the report. But the community information exchanges is another area where we're learning a lot. And actually in one of the pilots, Unite Us is probably going to be one of the linkages. But there is interest in the CIEs and WIC, and different from the electronic health records and some of those systems that are connected to healthcare. They should be more accessible by all the WIC agencies for getting referrals. What we're learning as newbies to this, you might all know much more than this. It's a closed loop system so that, the CIE can see how the referral went and, get some evaluation information. Right now, that's a challenge for WIC because except for aggregate data, WIC can't provide individual identifying data. So we're trying to learn about that and see how we might be able to continue to improve linkages with the CIEs, but at this point, it's mostly to WIC, one step at a time. And the issue here is working out the consent to share when the data is leaving WIC. And WIC does collect consent to share information, and there's now that more visits are being done remotely, that and WIC has its own MIS system, and documenting that there's some details that have to be worked out there, and technologically and with staffing. So next question, or next slide, please. And then we just, this is you, Lynette, go ahead.
That's fine. We just wanted to briefly touch on, there are some other linkages outside of healthcare that are in place. One example being with CalFresh, particularly agencies that are part in counties that are part of the CalWin consortium. There is a WIC referral field built into that. Apparently it's been there for a while, but in a lot of counties, it's only over the last few years become identified as an opportunity. And so we do know of WIC agencies that have worked with their CalFresh counterparts in their county to get automated referrals through CalWin. Maybe a broader opportunity than is currently being used. And then next slide is about linkages with Medi-Cal. We are aware also of linkages where WIC agencies are getting access to health plan data as prenatal and postpartum women become enrolled in Medi-Cal, and that allows WIC to outreach to those women, very quickly and get them enrolled in the WIC program if they're not already accessing the program. And that has been very successful in at least one agency in getting pregnant women into the WIC program very early, where they can maximally benefit from the services. And next slide just is to touch on, there are a lot of other cross referrals and coordination going on between WIC and other programs in their counties or communities. I've listed some of them there. Some of these are data exchange models that have been automated or some form of electronic data exchange, but a lot of them are still phone calls, pieces of paper, faxes. So there's a lot of opportunity to make those kinds of connections more efficient too through electronic referrals and data exchanges. And next slide, I think is you, Karen, just to comment on consent.
Yeah, just to summarize, and I'm sure this is nothing new for you, but just to kind of put it in the WIC perspective, consent to share is critically important for WIC, for confidentiality, and historically, and still in use, paper was the main way of doing this. WIC Wise is the new state California WIC MIS system. And so staff scan and upload consent to share to that, which is, of course, is a step. Or during the COVID, they have the flexibility to read it and sign on behalf of the participant. And then some of the agencies are looking at electronic ways for signing documents. Ideally, we would like to see this streamlined with the MIS. And we're hoping that with some of the statewide work around consent and data sharing, that there'll be opportunities for WIC to be included in some of this. So the next slide. And this just kind of share as a summary of the sort of the spectrum that we're working with right now. There still are pieces of paper where people, you know, bring in or scan or send a photo of their referral, and then trying to connect with the HIEs and the health electronic health records. And in doing this work and learning about what's happening, we are seeing how the WIC agencies are getting the data when it is shared. It could be a daily digest. It could be an individual file for each participant. It could be an Excel spreadsheet, and then that information has to then be translated and transcribed into the WIC MIS system. It's not interoperable at this point. So, you know, again, it's some steps on the WIC staff's part. So that's kind of where we're at as far as the actual hands-on work that the WIC agencies and partners are talking about and sort of learning more about and thinking about how to improve. So next slide, please. And that was our update. And I see a couple questions in the chat. I'm just going to go to the question from Christine. You asked about the WIC data. I won't go through all the data that WIC needs, but it's pretty basic and would be data that's normally collected in a well child visit or a postpartum.
No, I actually meant the other way around. So having done a lot of public health nursing, we've actually found the WIC data plugged a lot of holes that were in the clinical data from the child's primary care provider. So that was my question. So getting the WIC data out and back into the primary care record, because they'll think that the child has failure to thrive because the kid goes and gets their vaccines at the county vaccine clinic, skips their EPSDT visits, and then they were, you know, born at 9 pounds, but their parents are all, you know, 5'1", 5'2", and, you know, weigh 120 pounds, and then they want to send them to endocrinology. So I've just seen several of these cases, and so that's why I asked about the other direction, which I think you were talking about at the end, that you're very actively looking at that potential to be able to export the WIC data, but it doesn't sound like it's happening systematically anywhere yet.
Correct. There's very strict regulations around sharing, identifying data back. So we're trying to understand and learn how we can get that consent to share with other systems and share that data. Both directions. I mean, you know, when it comes from the EHR, that's obviously easier because the consent's happening on the other end. But going from WIC out, and WIC wants to be a good partner, and they need to discuss a lot of that data, like the examples you just provided. And so being able to do that is definitely the end goal here. So.
And Karen, I think relatedly, a question came up in the chat around using, you know, WIC data or WIC providers, you know, for screenings for HEDIS measures for health plans. Is that are health plans able to do that? Is that happening anywhere, or maybe are health plans, you know, incentivizing access to WIC in any way?
Well, we're hoping in the new contracts that they'll open up some opportunities. So we haven't seen that WIC is specifically called out on those, but it falls under some of the larger incentive buckets for the health plan. So the WIC agencies and CWA have been meeting with as many health plans as we can to talk about how that could be a beneficial relationship. So we're hoping there's opportunities there.
Yeah, definitely.
You know, there's always been these, you know, these MOUs that, you know, have been established between health plans and WIC agencies. Those have been around for a long time, you know, but they tend to be pieces of paper where there's not efficient action, I would say. I mean, referrals have happened, you know, usually very, very paper-based, where a piece of paper is given to the family and then they're supposed to figure out how to maneuver and access WIC. And so what we're hoping for is a much more efficient, streamlined process to make it far easier to get people enrolled in the program.
Excellent. Claudia, I see you have your hand up. I have one quick question. I think related to that, Linnea, as the state is putting together its data exchange framework, what would be helpful for, your WIC members that seem to, look and operate and kind of share data differently? What would be helpful in the data sharing agreement and the framework that's being developed to help meet your constituents' needs?
Well, I think one area that Karen touched on is this whole kind of universal consent. We can figure out how to incorporate WIC into that consent process and address the specific USDA Food and Nutrition Service requirements around that. So there can be an exchange of data, because right now that is a key barrier from the WIC side of things, of WIC sharing data with others. And then I guess, from looking at it more globally, establishing efficient referral, whether there's portals or, there are a number of different ways referrals could get to the WIC agencies. And that, and again, it can be a referral, or it can be some form of relationship where WIC can identify patients who are eligible for WIC but aren't receiving it, and can do, a targeted outreach to those. Karen, did you have any other thoughts?
No, I think you summed it up. Sorry, I'm also looking at some of the questions in the chat, but no, I think we're good on that.
Excellent. And Claudia, I see you have your hand up. I'll give you the floor.
Thanks. I'm Claudia Williams. I'm the CEO of Manifest MedX, and we're a statewide HIE across every county in California. My question is, we would be so eager to give you access to HIE data, but it's not clear from this conversation what the legal framework would be for that, since for those entities that are not falling under HIPAA. So I'm curious whether in some of these other HIE conversations you've had, if you've developed a framework that would allow an HIE to share data with your WIC offices or with WIC, WIC Central, when there's not a clinical provider involved.
That is exactly what we're working on in the 2 pilots. And and I saw a couple questions in the chat. WIC is under the purview of USDA, and very strict confidentiality rules from USDA. Is not under HIPAA. So that's a little bit of a difference. But yeah, in these 2 pilots, we are actually in this part of the pilot as far as working out those agreements for how that might be shared. One of the pilots is in an FQ, and the other is in, as Linnea said, a nonprofit that doesn't have a connection to healthcare. So
one just suggestion and an idea. There's been some really great OCR FAQs around whether consent is needed for healthcare providers to share data with social service agencies for care coordination. And essentially they've determined that consent is not needed if it's in the context of a provider or plan's care coordination effort. So there may be a pathway there. It would require getting everyone around a table and understanding that, because our issue is we're not allowed under HIPAA to share outside of HIPAA. But basically OCR said, yes, it's okay, but it has to fit under the rubric. So for instance, if a plan was trying to increase the WIC enrollment, I think that would fit under that sort of guidance.
And that is the understanding that the group that is working on the pilot with the nonprofit being able to access the HIE is that when the referral is made, that physician has decided that WIC is a part of the patient care plan. And that would then give WIC access to the data needed to fulfill that patient part of the patient care plan. So that is, currently what we're operating under to put this pilot into place.
Excellent. Well, thank you, Karen and Linnea, so much. This has been really educational and informative. And I know some other questions have come up in the chat. And maybe we can continue the Q&A in the chat a little bit if that sounds okay. And would welcome you back to present again if there are any updates that you're able to share. And I think we'd love to make sure that I think I heard consent and referrals and eligibility really come up as key needs when it comes to data sharing. So we'll make sure those are noted going forward as well. But thank you so much for your.
Yeah, I see the chat, and I just want to thank everybody for their good questions, especially Doug. You have a lot of good questions and ideas, and appreciate the help and engagement. And we're open. We're learning, so we're open to anything you want to share with us or ask us or suggest we do. So thanks very much.
Yes,
Thank
thank you
you.
both. Excellent. I think we can move next to our next guest presentation. William, would love to hand it to you for a brief CalHop overview and a snapshot of some of the outcomes you saw with the CalHop incentive program as well.
Sure, thank you. Is your team seeing the presentation now?
Yes.
All right, excellent. So thank you for the invitation to speak today. My name is William White. I was the project manager for CalHop from roughly August 2020 until the close of the program in September of 2021, and was pretty heavily involved in most components of the program over that period, including development of the contracts, policies, and ultimately the operation of the program. So what I'd like to do today is talk about some of the final outcomes of the program, as well as provide a very high-level overview in case there are any participants on the call that are not intimately familiar with the program itself. So just sort of diving into that. CalHop foundationally was a program intended to support providers and hospitals in onboarding to an HIE. The structure of the program was such that payments from our HIE grant were issued to a participating regional HIE, or what we refer to as a qualified health information organization under the program. And these payments allowed for those HIEs to offer services to providers at significant reductions, or in some cases at no cost, to achieve some of the milestones that we outlined under the program. Ultimately, we participated with 7 HIEs throughout the state as part of the program, and under CalHop had $50 million available in potential funding for onboarding milestones and other milestones around advanced HIE interfaces, with the caveat that all of these funds and all of this work had to be completed by September 30th, 2021, due to the funding being tied to the HITECH Act and the restrictions of completing work under projects under HITECH by that date. With respect to our QHIO participants, there were a number of qualifications that we set forth. Foundationally, we offered participation to any HIE which met these requirements. And then, as I mentioned, ultimately had 7 that ended up participating in the program until the end of the operations. Firstly, that these HIOs had to be a California-based nonprofit. They also had to additionally demonstrate sufficient financial stability, insurance and liability coverage to conduct operations in the program. They had to commit to participation by any service provider within their regional area, meaning that if a provider organization within their scope of operations was interested in participating, they could not be denied for any other business consideration outside of their interest in the CalHop program. And then additionally, we required that the providers, or that the HIOs, demonstrate sufficient interest in onboarding through their organization by providing upfront 10 letters of interest from participating providers or prospective providers in the region that would be interested in fulfilling the CalHop milestones, and required that 2 of these letters be from hospitals within their network area. We also required all of the HIOs to be participants in the CalDERSA and the C10. For participants on the provider side, the requirements were a little bit more streamlined. We simply required that they have a contract with DHCS or an affiliated Medi-Cal plan, whether that's a managed care plan or a behavioral health plan, to bill for Medi-Cal services, and additionally affirm through that letter of interest that they had sufficient resources and technical capability to achieve our core milestones. Moving into some of our program metrics, under CalHOP, we had 390 total provider organizations that participated in the program, including 63 unique hospitals and 327 what we refer to as ambulatory provider organizations. And these truly are a wide swath of different complexity, particularly in terms of provider organizations. We have quite a few solo practitioners that participated on the program, as well as organizations as complex as a multi-hospital network that also includes outpatient ambulatory services and affiliated satellite clinics. Because of the way that we structured the program around one participant equaling one EHR system, the participant volume in terms of providers served could really range from 1 to several hundred, or perhaps even several thousand, depending on that participant and the number of practitioners on a specific EHR. Under the program, we made a total of 22.4 million in milestone payments to various provider organizations, and additionally paid 1.8 million in support for modernization of the Controlled Substance Utilization Review and Evaluation System. Sorry, that's a mouthful. Or CURES, which is administered by the Department of Justice. And we also support the development of each of our participating HIEs to facilitate a connection to the CURES system directly to the HIE for accessing and reporting back to CURES. In total, that amount represents about 48% of the total available budget. And we'll see in the next slide a breakdown of payments issued to HIO partners over the course of the program. The way that the CalHOP program was initially structured is that each HIO participant was given a $2.6 million contract to complete milestones, and then under their initial onboarding plan, if they met a significant amount of their initial planned interfaces, they could pursue further amendments to increase their contract as long as funding continued to be available. And you'll see just based on the graphic here, which is also available as a dashboard on our CalHOP website, that we had a number of organizations which stayed within the bounds of their $2.6 million contract and were very successful in meeting their initial plan, as well as a few organizations that were able to complete a significant amount of work early on and then move forward into additional contract amendments and additional workload. In terms of completed milestones, we had 4 milestones under the program. The first being essentially just onboarding to the HIE, which is to offset the contracting costs for working with the HIE. And then we had milestones centered around ADT transmission, connection to CURES, and then what we referred to as advanced interfaces, which was a number of different options around more sophisticated CCD transmission, more sophisticated ADT transmission, connections to other public health registries such as CalRadiant Care, and provided a lot of options for providers to customize the services they had under the program. As you'll note on the slide, over 89% of providers that participated achieved the ADT and CURES milestones. Those were actually required as part of the program to be completed by September 30th. And so that number is perhaps less surprising because if those milestones weren't completed, there was the potential for offsets or clawbacks of the initial contracting milestone. The other 11% that did not achieve ADT and CURES, a large number of those actually do reflect organizations that were able to achieve a qualifying exemption. Usually that meant that they had one or the other capability before joining the program and were using sort of program funds to achieve the other goal and then achieve the advanced milestones available under the program. Finally, as you know, 87% of participants additionally completed advanced interfaces under our milestone 3. And that I think is a great testament to the work that our HIO partners did over the course of the program, as it was essentially a completely optional milestone. And so in some respects, you might consider that to be much lower, but it's actually very closely tied to the essential required milestones under the program. We also found that in our final metrics, organizations with 10 or more providers were more successful in achieving both those ADT and CURES milestones and our advanced interface milestone, which perhaps is also unsurprising as they typically would have more IT resources and support staff able to facilitate interfaces under the program. On the next slide here, again, just a breakdown of milestones achieved by each of our HIO partners. I think what is interesting about this slide is that there isn't a significant variation in terms of one HIO or the other being more successful in achieving milestones across the board. For example, there's no indicator where one HIO is achieving milestone 1, 2A, 2B, but drastically not achieving milestone 3. It's pretty consistent throughout, and I think while there is variation, obviously, in the number of milestones achieved based on how much contract dollars they eventually pursued under the program, each was fairly consistent in making sure that all those milestones were met. Moving on to some final thoughts about the program. One of the efforts that we're currently engaged in as part of the closeout to all high-tech programs is an HIT landscape assessment, which we've contracted with the University of California, San Francisco to conduct fairly substantive research in several spaces of HIT utilization throughout the state. One of the aspects of that research has been to conduct interviews with CalHOP participants and identify some of the key takeaways and key outcomes of the program. We found through that survey that the program is generally regarded to have had broad benefits for participating HIOs and providers, that HIOs were able to onboard new provider types not commonly enrolled in an HIE. Part of that is likely the ability of CalHOP to provide funding for organizations like standalone laboratories, skilled nursing facilities, behavioral health providers that were traditionally excluded from the HIE incentive programs. And then additionally, one of the major setbacks for the program was the short time frame, which limited the number of participants that were able to be onboarded within the scope of CalHOP, as did the competing demands, obviously, of COVID-19 and our sort of collective response to that crisis in terms of the availability of health professionals, IT professionals, EHR vendors, and others to respond to requests from HIEs to perform these services. I will also note that the full UCSF report, once completed, will be posted as an addendum to our updated state Medicaid health information plan, which is currently under review, or soon to be, I believe, under review by CMS. And once that's finalized, will be posted on the DHCS website as well. So I will then just open it up if there are any questions. I haven't been able to monitor the chat, so I'll turn to that now.
Yeah, thank you, William, so much, and looking forward to seeing the landscape assessment once it's published. Can you speak at all to you mentioned the UCSF evaluation and the benefits to HIOs and providers? Can you give us maybe just a little bit of detail on what were maybe some of the benefits that you found through the CalHOP program?
Sure. So I think one of the benefits that was specifically called out in the interview and sort of data analysis was that a lot of smaller providers and a lot of providers in areas that are not typically served by HIEs were able to be accessed through the program. And I know a couple of our HIE partners may actually be on the call, so they may be able to speak to this as well. But it provided a capacity for reaching those that might normally have had the resources to engage in this type of process.
Mm-hmm. That makes sense. And one question came through from Deanna at CPCA. Do you know what number of participants were FQHCs?
I don't have that data readily available. I may be able to look into that for you, Deanna. I'll take a note back.
Awesome, thanks. And I guess one question, is as much as maybe you can provide, what, now that high tech is sunset and the landscape's coming out, what are kind of future plans from the department's perspective in terms of supporting HIE or interoperability? What areas of focus might be rising to the top for you all?
Sure. Unfortunately, I don't have too much information to share on those efforts, as I'm no longer part of those discussions. I would expect that probably our AB 133 work group is the best place to look for information on those efforts.
Perfect. Well, we'll make sure to follow up with that work group. But thank you so much for your time, William.
Thank you.
We appreciate it, as folks are thinking about future incentive programs for HIE. So this is really helpful.
Sure. Thank you. Happy to be here.
Excellent. Thanks. All right. I think we can turn back to our our regular meeting materials. I guess on the topic of data sharing, an upcoming meeting that's part of the data exchange framework work will be on the 26th. Of the data sharing agreement subcommittee will be meeting to have their last meeting before the full draft of the DSA and the data exchange framework is shared on the 11th of May. And some other key dates coming up too are that on the 18th of May, those full drafts will be released for public comment. And then in June, public comments will be due in July. We'll see the final data exchange framework and data sharing agreement as well. And we are planning, next week to dive, or excuse me, in 2 weeks to dive in a little more depth into the data sharing agreement. Once the next subcommittee meeting is held next week, to be able to assess out where there may be issues or gaps with it, and whether it, in participants' views kind of, meets your needs, or how can we think about starting to shape an outlook or comments to the data exchange framework folks as well. So moving to our next item, just in case you missed last week, we had a really great presentation from our friends at Intrepid, from Mark and Karen, around some work they've been doing with California Healthcare Foundation around educational materials on governance, as well as different levers that the state can pull in order to, help promote or require data sharing. So would definitely recommend, if you missed our meeting last week, to check out the recording and also the publications from CHCF as well. And we can make sure to put those in the chat. One other item, so a recent news item that came out was just in health IT analytics, just around, lack of data readiness, preventing healthcare innovation. I don't know, Mary, is there anything, I know Innovacer was part of this, any detail or highlights you'd like to share from this article that was published?
I'm sorry, Robbie, which article are you looking at?
The health IT analytics one with Morning Consult.
Yeah, not really. No, I mean, no. Is there a key question?
Oh, just around, it highlighted, how interoperability is one of the key issues to, the spread of innovation, and, that execs and, other business leaders really highlighted that in the survey. I don't know if there was anything in particular that you might want to touch on, as we just shared this news article in the roundup.
Yeah, no, thank you. That's great. Yeah, no, I mean, data readiness is just critical. I really don't. I think it's pretty self-explanatory.
Mm-hmm. Awesome. Well, thank you. And thanks for sponsoring this work as well. Yeah.
Oh, no problem.
One other news item, just to make folks aware, is that ONC is also having a forum tomorrow around SDOH and challenges and opportunities when it comes to exchanging SDOH data. So I think that's a nice follow-up from our guest presentation recently from the Gravity Project as well.
Yeah, this is part of a larger series that ONC is doing. They did one earlier last month, and they're doing 3 others in May, June, and July, so watch out for those. This one will be focused on kind of setting the foundational elements of the SDOH landscape, and the coming months will feature governance and other issues related to SDOH data exchange.
Excellent. And just 2 other policy updates that we wanted to share as well. So regarding SB 1033, so that was the bill that's regarding health plan collection of patient data, including SDOH and race and ethnicity data. That bill did get out of the Senate Health Committee yesterday, so it'll be moving to Senate Appropriations. And we can drop the information in the chat from CPEN in case folks are looking to support the bill as well or monitor it. And as well, we just wanted to provide an update on the budget as well, and an upcoming budget subcommittee hearing opportunity to voice support for the efforts ongoing around HIE incentives. I don't know, Felix, if you'd like to speak to that a little more.
Yeah, always happy to, Robbie. Thank you. Yeah, so as Robbie alluded to, and actually as I think we announced last week, the Department of Healthcare Services, whom we just heard from, a very obviously helpful update on overview of CalHOP. They are going to be presenting a budget change proposal on May 2nd. So that is not next Monday, but the following Monday. That the hearing date got moved. But that provides an opportunity for those in this group that are also supporting or supportive of our 95 million Medi-Cal data sharing equity budget request to call in during the public comment portion of the hearing. And basically, reference the budget change proposal, thank the administration for highlighting the importance of resources for data sharing and to also basically, support and affirm, our backing of the stakeholder-led $95 million budget request for data sharing equity. I think probably what makes most sense, Robbie, is for next week's weekly roundup, we can include a reminder for that May 2nd hearing date, the call-in information, as well as maybe a link to a very, very short suggested set of talking points or script that people can use if it makes them more comfortable about calling into the hearing. So as always, we really value the solidarity that the coalition has shown behind getting more resources for HIE. And this is one of those very rare and very crucial opportunities to actually have your voice heard as a member of the public.
Excellent. Thanks, Felix. We can definitely share that update. I know, Claudia, you said you had an update too as well around info blocking, if you'd like to share that one.
Yeah, I'll try to make it quick. I know we're almost out of time. So this week at the State Health IT Connect meeting, Mickey Tripathi spoke, and he shared a really important clarification that if there is a law or policy that requires proactive data sharing, meaning not in response to a query, but proactive, and that there are two examples listed. One was public health reporting. The other was hospitals sharing ADT alerts after a patient is discharged with a PCP. He said, if there is law or policy at the state or federal level that requires proactive data sharing, an entity that doesn't do that would likely be considered in violation of info blocking. And this, I think, is both important from an info blocking standpoint, but it's also important as we think about which parts of data need to be shared proactively under our state data sharing framework. So if we're going to require ADT data sharing from hospitals, this means that compliance with that would be, lack of compliance with that might be considered an info blocking violation. He shared an FAQ, and Robbie, I can share that with you if you'd like to share it with the group. And it's kind of in the weeds, but it's also very substantial and significant when it comes to thinking about our state policies.
That's great. Yeah, we'd love to share that, Claudia, and take a look at it as well. And I think too, like you said, figure out how it is implicated in the data exchange framework as well. Excellent. Well, just going back one slide real quick, Kira, if we can, just a snippet of our upcoming programming. Like we said at our next meeting on May 5th, we'd like to dive into the data sharing agreement a little further. And then our subsequent meetings, May 19th, we'll be joined by our colleagues at Civitas Networks for Health. They're the national trade group for health information exchanges and regional health improvement networks. And then we'll also hear in early June an update from Cal Mesa on the semi-statewide EHR project that they're pursuing for county mental health agencies as well. So we'll get an update on that project and kind of how it fits within the data exchange framework and larger data sharing efforts. So those are our updates for today and our programming. Thanks so much to everyone for joining today, and to our guest speakers for all the materials and time you put into that. Really informative around WIC and CalHOP as well. So thank you. Thanks, everyone, and have a great day.
Thanks, everyone. Thanks for a great program.
Yeah, thank you, Doug, for all your participation.